I have personally been involved in a number of efforts to better understand what the value is for the various interventions we have for multiple myeloma. We often talk about cost. We rarely talk about the whole equation, about value. Now, we all should be mindful and should be concerned about the high prices that some of these medications command. But on the other hand, we're seeing the benefit, both directly that our patients express by having their disease control, but also as economics, analysis are done and we interact with economists by the downstream beneficial effects of this. People that avoid hospitalizations, people that avoid blood transfusions, or people that can return to their productive economic life. So when we talk about the economics of drugs, it's insufficient to merely talk about cost. Furthermore, the discussions about cost are highly limited because people use frequently the sticker price when they do this analysis, and we have to consider the aspects of the rebates, and in particular for patients. Sure enough, there's some implications for how much the premiums will be as we introduce some of those more expensive drugs. But for the patient in the front line, in the need of treatment, the focus is on the copay portion of their responsibility. We did an analysis regarding the economics of the treatment of multiple myeloma, and this was agnostic to the drugs. We're not trying to prove that a regimen was more effective or not. And we actually compared this over a number of years using a claims data set. This was published in Leukemia in 2017. And what we realize is that the analysis of this is pretty nuanced. There's many other costs that come into play, including expenses associated with the office visits, expenses associated with hospitalizations, expenses associated with the administration of these medications. So we do show that, in fact, these medicines do contribute in the cost of the care of myeloma patients. But they're hardly the only driver. And in fact, there's other areas that appear to be driving the cost higher. So we have to look at this in a holistic way, if you may. There's some previous analysis on how some of these agents in particular have reduced health resource utilization because of the prevention of complications. And we're currently involved in studies that are trying to look at the economic burden of a recurrence. In fact, we had a poster like that at this particular meeting because from a payer perspective, if a person experiences a relapse because perhaps a less effective regimen is used, there's going to be some cost that is going to be incurred because of the need for the rescue of the complications from that disease progression. As clinicians, I firmly believe that my only responsibility is to the person in front of me. Now, I realize in the system we have where there's a third-party payer, we have to work within the boundaries of what that payer may allow us to use or not. Now, on another day, I can take off that hat and I could be a policy wonk and I could be advising people on what I think is proper or not. But physicians at the bedside need to focus exclusively, 100%, on what's the best for the patient and advocate for that. I can't imagine how a conversation would go with someone saying, listen, there's this great drug, whatever that drug is, but I just feel like we're spending too much money from the plan. How that is a complete betrayal of what we call the fiduciary responsibility for physicians as they're dealing with patients. Now, the physician needs to discuss the economic implications of whatever treatment they're doing with patients, but the reality is for that person, it comes to the co-pays. This is simple enough for those with commercial insurance because there's a number of programs. Now, that needs to be told to the patients. They need to know those programs exist. And it's quite a bit more complicated in Medicare beneficiaries just because of the impossibility of the direct assistance for the co-pays. There's some discussion going on right now with classes of protected drugs, copay accumulators, etc. But that is where the boundary exists for the stress for patients and the copay contribution to their care. There is a possibility that we will be facing, and not surprisingly because of the higher cost of these medications, more hurdles or difficulties in the access of some of these medications. So far, this is mostly manifest in the form of the prior authorizations that we have to obtain all the time. The logic behind them, it's sometimes not there, but I understand it's very hard. As a payer, you want to follow your guidelines. And as an example, just this morning, I got a denial for cyclophosphamide, the cheapest agent in a combination. And I almost feel like there's no logic behind that because it was just not on the pathway. I am personally very concerned with the idea of step therapy or what's called fail first. This is a way through which payers can decide that you cannot get a drug unless you try something older and cheaper. Now, I can totally live with that if we're talking about chronic hypertension. Maybe you try a diuretic, and if that doesn't work, you go to a beta blocker. That does not work for cancer. It doesn't work because you're going to expose patients to ineffective treatments, potentially create resistance, and certainly have the possibility of having the patient experience some toxicity that they did not need to have. So I think we have to be very careful about this. I've explored the topic. There's a recent white paper by Professor Sharona Hoffman from Case Western University that looks at the ethical and legal implications of step therapy. And in fact, I released a video with my interview of her. I think there is a question of how much synchrony there is between payers and physicians, and everyone has their own interest and their own stake, and rightfully so. That's how the system works. The biggest challenge is that how do you create that synchronization between both parties? Medicine is very complex and is becoming very, very complex. So after a meeting like this, many of us who only devote our lives to multiple myeloma and we think about nothing else but multiple myeloma still scratch our heads of what's the proper next step for therapy. Is it logical? Is it proper? Is it even fair to assume that a payer is going to be able to understand that? The answer is no. Is there an easy solution? No. Because a payer is going to be looking at, okay, what are the drugs that are approved? What do we have FDA approval? What does the NCCN says? And then based on that, we will decide on whether we will provide coverage or not. For a payer to be able to make medical decisions, they would have to be in the room of the patient because every patient is unique. And this is not a cliche. This is just the reality of what we see in cancer practice. We cannot create cookie cutter guidelines for most of the diseases. I can speak with authority about myeloma. It's my area of expertise. But I can only imagine the same is true for lung cancer and breast cancer, etc. So it is a very complicated situation right now. Now, on the positive side, we're at a meeting where we're seeing CR rates in a large fraction of patients. We're seeing MRD negativity on multiple myeloma, which we could only hope for in the past. So I think that everything is moving in the right direction, but with significant tension and friction.